Welcome everyone to ABG Sundal Collier Investor Days. My name is Viktor Sundberg, and I work as an equity research analyst covering the healthcare sector. And today we have the pleasure of having Saniona with us here today, and Jörgen, the CEO. And I will host a short Q&A after the presentation. So please, Jörgen, go ahead.
Thank you, Victor, and thank you for the invitation to be here at the ABG Days. I'm Jørgen Dreyer, co-founder and CEO of Saniona. It's a Danish biotech company, and we are listed here in Nasdaq Stockholm Small Cap. So we were founded back in 2012, and we are focused in the orphan disease space, in the rare disease space. And actually, we came out with some very encouraging phase 2 data just a couple of months ago on our lead product, Tesomet, in one of these rare diseases, Prader-Willi syndrome. I'll get back to that. So, with the introduction here, we, as I said, are focused in rare diseases. And the product Tesomet we are developing in 2 diseases, in Prader-Willi syndrome and in hypothalamic obesity. And we have the intention of going all the way from these phase 2 data to the clinic and actually to market the drug. We see a very interesting market opportunity here in the billion-dollar range in both of these indications. So although the diseases are rare, the prices are high and the market expectations are really big. We also have founded the company on a very solid technology base. And these programs have come out of that, but also a number of other programs that we have partnered over the years. We've partnered with Pfizer, with J&J, and also with Boehringer Ingelheim and several other companies. And all these partnerships have actually funded, paid for all the research we've done over the years and even some of our clinical studies. So I also claim that we have a profitable platform business on top of the orphan drug. And this has also delivered new programs into our own pipeline that we could position in the orphan disease space. So I think although we are a biotech company, there are not that many biotech companies at this meeting today and tomorrow. And it's perceived that there is a very high risk in biotech, but also a very big upside opportunity. And that is, of course, very true. I think Saniona is a little special in that respect because we have some programs that we really know works in the clinic. We have shown that in the clinic, which is the main risk in the products. Also, we have a broad pipeline, so therefore we risk diversify. And also, we have made all these partnerships that have paid many of the costs. Here are some information about the company, market cap of around 800 million Swedish. So now I'll show the pipeline with this product Tesomet in the top for these 2 indications I talked about in phase 2 and where we want to bring it all the way. We have 2 other programs here that are currently positioned for partnerships. They come out of our ion channel platform, but as I said, could also be positioned in the orphan disease space. And then a number of other programs that are currently partnered. I'll not go into details with that now. Maybe if we have time by the end, I can talk about a few of them. But there is a Boehringer deal here. And also, I will just mention the collaboration that we have with Medix in Mexico, because they are now in the process of filing for an application for the drug tesofensine in the obesity field. They just completed phase 3 studies about a year ago and have now done the registration package. So we expect them to be able to market our first drug next year in Mexico. So tesofensine, Tesomet, I'll mention these products a number of times in this presentation, and it actually, Tesomet is also based on tesofensine, this unique weight loss drug, but this is a combination drug, a better version of tesofensine, I can say. We'll come back to that. So the Tesomet product we see as a go-to-market opportunity in these 2 orphan indications, Prader-Willi syndrome and hypothalamic obesity. And these two diseases, they are rare, but they are also terrible diseases. They are characterized by a number of problems, but the main problem is that these patients have no appetite control whatsoever. And this is really life-threatening, at least for the Prader-Willi patients. They will have such an urge to get food into their mouths that they can suffocate from the food. They can have bowel rupture because they simply just continue to eat and eat until the bowel ruptures. And there's a very high death rate due to accidents in this disease. So we need to control them all the time. There's a low prevalence, but we estimate the market potential could be in the order of $3 billion. The other disease I'll talk about later, but this is a genetic disease. This is actually an acquired disease where there's also a complete loss of appetite control, and there's also a $1 billion market opportunity there. I mentioned we just completed the phase 2A studies in the Prader-Willi syndrome, saw very encouraging data, and now we are preparing for the last part of the development, the pivotal studies, phase 2B, phase 3 studies, and potential filing in 2022. In the other indication, we are in the middle of the phase 2 studies and have just completed the recruitment in the study and should read out about half a year from now. We think the rest of the development could be faster and also the potential for filing in 2022. So actually we have two very interesting opportunities here, which is also provides some risk mitigation. So I already talked about the disease, Prader-Willi syndrome, some of the characteristics of the disease, which is caused by a genetic defect. This addiction, obsession with food, and also a short life expectancy. And these patients also have other problems, but in the most problematic, the hypophagia, we call it, this urge to eat all of the time, really means that the caregivers need to be looking at them all of the time, need to lock up all food and so on. They also have some intellectual disabilities which make it even worse. There's been a company in the field that showed how the market potential could be. They showed how the clinical studies could be, how the regulatory interaction could be. That was a company called Safdine. And there were a number of analysts following that company and estimated a $3 billion opportunity in the Prader-Willi syndrome, divided in US, Europe, and Japan here, and with a pricing structure like this. We think this is a very interesting business opportunity for us because we can do the studies, these very small studies, 100, 200 patients, short studies, and also we know all the patients, all the patient organizations, at least in Europe and US. Now to how the drug tesofensine works, and then I'll also get into what Tesomet is. It's a drug tesofensine that will increase the levels of these three drugs in the brain, these three transmitters in the brain: dopamine, serotonin, and noradrenaline. Dopamine is essential for controlling the reward system, so you can actually decrease the craving for food by pushing on dopamine. Serotonin and noradrenaline are very important for regulating appetite, so by pushing on these, you'll reduce appetite. And on top of that, noradrenaline also will increase the general burn in the body, the general fat burn, which also contributes to the efficacy. But it also increases the heart rate, the pulse. And that is a reason why we do not want to develop tesofensine in chronic diseases as the Prader-Willi syndrome. There we prefer the better version, the Tesomet product, where we've added a so-called beta blocker, which take away this increase in heart rate. So it's a completely cardiovascular neutral drug. And also with that combination, the Tesomet, we have a completely new patent position. I mentioned tesofensine is a very, very effective weight loss, probably the most effective weight loss drug in the world. And this is just a study that was done several years back, an obesity study done in Denmark using 3 different doses. And what you can see is that the loss of weight in the tesofensine group, for instance here in the mid group, was around 11-12% of weight loss. And that is really unique. And if you take that out to 1 year, this would be about 15% or 14-15% of weight loss. And this is all driven by the effects in the brain, by the reduction in craving for food and in appetite, which is shown on these scores. And it's exactly this level of tesofensine, 9 nanogram per mil, or around 10 nanogram per mil, you need to get this efficacy. So we decided to go into these rare diseases, into Prader-Willi syndrome, because this is exactly what is the problem here. Craving for food, a loss of appetite function. So we did actually several small studies in 18 patients in total, both in adult patients and later on also in teenagers. And we did different doses and different treatment lengths, both placebo-controlled and also open label. And this is, I'll not go into much detail here, but this is really an overview of all the things that was done in that phase 2A study. First in adults at 0.5 milligram, then in the teenagers at a quarter of the dose, 0.125, and then continued in an open label at the same, and then continued into another open label at the double dose. And this was really to get as much information about this patient population and the drug as possible. So there's a number of measurements every month during the study. These data from the study have been presented at the International Prader-Willi Society meeting in Havana just a couple of weeks ago, and this was really very well taken there. So I'll not show all the data again, but just to give a summary of what we see. And in this schematic version, you can see the 3 different doses that were used and the different levels of the tesofensine in the blood, 4 to 6, 8 to 10, 20 to 40, and also the effect that we saw on this hypophagia, the craving for food, and also on the weight, BMI, and the tolerance. So what was seen, conclusion is that it's the 0.25 milligram that gives us the right level of tesofensine in the blood, and that gives a very, very significant reduction in the hypophagia, 68%, and also a very nice weight loss in just 3 months, 4%, which would be equal to maybe these 15% in a year. And it was very well tolerated at that dose. At the higher dose, we got very high in plasma concentration, in blood concentration of the drug, very good efficacy. But then at these very high doses, there was also some aggravation of existing symptoms and some dropouts. So this is probably too high for most of the patients, whereas the low dose was probably too low for most of the patients, but still very well tolerated. So that was the overall conclusion. And we followed, as I said, the patients day for day almost during this period, and have looked at plasma concentration. We've looked at the effect on weight, for instance. And here, if you just see this patient growing in weight all the time, then when you get to the 0.25 dose, he drops in weight. And then when he gets out of the treatment, he takes on weight again. And we can plot this as a function of the level of the drug in the blood. And although there's of course, big variation day to day on weight, month to month, you can see that the monthly weight change goes down and down and down if you increase the concentration in the blood. And this is actually true for all the patients. This is just another one starting on placebo. And again, if you go up in dose in concentration in blood, you'll get in this range. And here we plotted all of them, and you can see the regression lines here. They will all lose weight, and this is the statistics on it. Very, very robust, although there are so few patients. We have p-values of 0.005, 0.003 here. So we can very well predict what the weight loss will be in this study. So the conclusion from the phase 2A Prader-Willi study is that we have de-risked and have a guidance for the pivotal studies, in that we have proof of concept in the PVS. We have found the right dose, 0.25 milligram, which is the right in both adolescents and in adult patients. We have a strong correlation between the effect and the dose and the plasma level, and also we know we can give the drug for a very long time, up to 9 months, and have learned also additional things that we'll put into the design of the next study, including that we'll have 2 endpoints, again reducing the risk of failure. So this is the clinical study that we will run in phase 2b, phase 3, 3 arms, placebo, a fixed dose of 0.25, and then the flexible dose where we start with 0.25 and go up to 0.375. And there will be a open label extension of that. And immediately after that, we'll run the same study into a phase 3 setting with just one of these doses. So it'll take about a couple, 2 to 3 years to do this. Now, the hypothalamic obesity, I mentioned this is not a genetic disease, it's actually acquired disease. It's a damage to the brain and this part of the brain where the appetite center is. Usually it's a benign tumor, craniopharyngioma, that grows into this area and destroys the appetite center. And it can also, when it's taken out, this tumor, that there is this damage. And then they lose the appetite control, and from one day to the other go from slim persons to very, very big persons. Cannot control the food intake at all. And they get a number of other disease complications on top of that. The prevalence probably a little lower than in Prader-Willi syndrome, but otherwise we think it's at least as simple, maybe even simpler to do the clinical studies here. As I mentioned, we have just completed recruitment in the study, and the first patients are now through the double-blind part of the study and into the open-label extension. So we read out in Q2 next year. And are very optimistic based on what we've seen so far in the other indications here. So tesofensine is now a very well-studied drug, and also now Tesomet. It's more than 1,700 subjects that have received the drug, 18 phase 1 studies, 8 phase 2 studies, 1 phase 3 studies, and here going up to 5 studies on Tesomet. So we know the safety profile of the drug very, very well, and it seems to be very well tolerated. I'll have a couple of minutes to talk about the rest of the pipeline, and so I'll not spend time on these 2 programs, which are unique drugs came out of our ion channel platform, showing treatment of a new treatment principle in pain and in itching, and this is for general inflammatory diseases and autoimmune diseases. This is phase 1 ready. This is where we selected a candidate recently. But I will show a couple of slides on the Medix product. This is a program that we spun out a few years ago with Atlas Ventures in US, and they have a product now that we'll get royalty on that's in phase 2 and got some interesting data recently. We have this collaboration with Boehringer in schizophrenia field, and we are doing studies in cocaine addiction. This is all paid for by the partners. So Medix is a leader in the obesity market in Mexico. They have their own clinics, have about half of this market of $250 million US dollars. And they have got the rights from us to develop and launch tesofensine in Mexico and Argentina on top of that. And we'll get double-digit royalties on that. They just completed this phase 3 study very successfully last year, now in registration phase and potentially commercialization from next year. So this will be very interesting for me personally, because this would be the first drug I would bring to the market. It was made in my labs several years ago, and it takes a long time to get there. So just to the near-time inflection points, there will be a lot of things happening over the next half year. And I mentioned with the Prader-Willi thing, we just got the data, and now we also expecting data in hypothalamic obesity, and we should start the pivotal studies next year. Tesofensine filing in Mexico, later in Argentina, and then a number of milestones in our early stage platform, going into phase 1 with this one candidate, bringing this into the clinic, new milestones in Caden, Boeing, and so on. And also we expect to make new partnerships deals on our early stage programs within the coming period. So I'll just end up by this slide, which is from Dora Tørak, who actually is the primary investigator in these Prader-Willi studies. And it's really very encouraging to speak with her when she comes and visit us, because she's seen these patients, and I think what she says is, to me, even more important than what we see in the data. She really believes this is a very effective drugs for these patients. Nothing else has worked there, and this is a statement that she put in the press release. Also, she says that several of the parents to the patients have come back to her after the study was completed and asking whether they could get some more tesofensine, because now the patients are taking on weight again. They have this extreme hyperphagia, and also the autism and other symptoms that they had are coming back again. So they are very convinced that this is a drug that works, and we need to get it to the patients as soon as possible. Thank you.
Thank you very much, Jürgen, for your presentation. So the next milestone, as you alluded to, is the hypothalamic obesity trial that will read out in the beginning of next year. So maybe could you highlight what would be considered a success in that study, and what the endpoints that you're looking at in that study are?
Yes, since it's the first study we do in this indication, we have put it up as a safety study just to understand whether this again, very atypical patient population, how they would react to the drug. But so far we've seen it goes very well in the first part of the study, so I'm very optimistic there. But we have a number of other endpoints, of course, that we are even more interested in, and one is the hyperphagia part. And there's an appetite score and other scoring system that addresses that urge to eat. And also there is, of course, measurements on the weight, on the BMI, and on all the metabolic parameters, because these patients are also getting very big, and that can have metabolic disease consequences.
Yeah. And how much weight would these patients need to lose in order for you to see a good efficacy signal? Or
yeah. It is considered the same in this patient population as it is in general obesity, that if you actually would be able to lose 5% of weight, then you'd get out of the dangerous zone where you have a higher risk of prediabetes, diabetes.
Yeah, and in Prader-Willi syndrome, you showed a 68% reduction in hyperphagia score for the patients that went through the study. And how does that compare to the competitors in the US that you mentioned here that had such high expectations in terms of peak sales and so on?
Yes, I mentioned the company Safgene. They're actually out of business now because that drug turned out to be toxic, but it was actually quite effective on losing weight, and there was about 30% reduction in this hyperphagia score. There are a number of other companies that also moved into the field. They're just addressing hyperphagia, not really the weight. They are usually getting about 20 to 40% of reduction in this hyperphagia score, depending on how you look at it. But this drug appears to have a much higher potential. We've seen 68%, and in the first study in the adult patient, we actually saw an almost 100% reduction in hyperphagia. It seems we can completely take away this drive in some patients. And also, Dora Tørak mentioned that some of the patients even left food on the plate, which they've never done before in their life. So I think this is uniquely more effective on hyperphagia. And then it, in addition to that, also works on the weight, and I think you need to have effect on both of these to get a really successful drug on the market. You may be approved on just one of these endpoints, but we think it's very important that you drive both of them.
And for the Prader-Willi, the next step, when will that study start, and how much do you think it will cost to run this study, and also the hypothalamic obesity study?
Yes, so we'll start the study sometime mid next year. We are now preparing for the filing for the IND in the US. This will mainly be a US study, and we expect the price tag in total will be around $30 million for these two years of trial. And so that is a big bill, but when you're getting into pivotal study, it gets very expensive. So one big part of that is the production of the tablets and all these what we call CMC expenses. But that we don't need to repeat when we go into hypothalamic obesity. So we expect the pivotal studies in hypothalamic obesity would just be $10 million US. So in total, $40 million to get these drugs to the market.
Okay. Yeah. Thank you very much, Jürgen. Thank you everyone for coming.